first one, which is on mature intumescent cataracts. So there would be three speakers, Dr. Deepak Magur, Dr. Subhash, and Rohit. So Dr. Deepak Magur, would you get?
Sir, my opponent in debate is also the moderator. We need to have an...
3 minutes. 3 minutes. 3 minutes. Yeah.
Good morning, friends. And I'll be speaking on the manual way of doing rexus in intumescent cataracts. And these are my two opponents here in the debate. And both of them are my seniors. And they're one of the finest surgeons in our country. And I have immense respect for them. I learned from them a lot. And the biggest joke or the irony is that these are the only people who don't require any of these fancy tools, and they're going to talk on how to use them in intumescent cataracts. My sympathies to you, both of you, sir, and because you can't justify the justifiable. अरे बच्चा जानता है, every kid, new kid world over knows that, you know, the only way or the safest way to do is the two-stage rexus, which is a gold standard. And it is given reproducible results in an average surgeon and new kid also. What we require is a soft eye, and you have to use good viscoelastics, and we have got a lot of economical Indian variants as well. And you need to have some fine forceps. Dr. Haldipurkar's forceps is the one which is my favorite. Of course, you can have the micro forceps and scissors of your choice. They give excellent control, maintain the chamber, you decompress the bag after creating the primary rexus, and then the job is done. It's a child's play. And you have a perfectly well-centered, appropriately sized rexus. This is an anterior-chamber depth is 1.73 millimeter in a phacomorphic glaucoma. I'm not sure you can place that Zepto device inside so safely. Again, the trick here to get the primary small rexus right, and apart from using a heavy OVD, if you use a tearing technique where the flap is kept flat and pulled centripetally, you can get the rexus perfectly well. And of course, then decompression is your choice. You can use a wide bore cannula, bimanual IA system, whatever you do. And once the bag is decompressed, the secondary enlargement is perfectly fine. You get a perfectly well-centered rexus in, I'm sure most of you have done tens of thousands of cases, including multifocals, torics, and premium cataract surgery can be done with just these technique itself. You don't require to have this fancy femto, zepto for premium cataract surgery. What you require is a premium surgeon for premium cataract surgery, not these devices. And of course, there's numerous statistical analysis which are available which substantiate my this thing. And this is a wonderful 3 crore machine which can also successfully inducing radial extension in these intumescent cataracts as well. So the current state of affairs, the sad state is we market them as robotic. We have a Bade Mia and the Chote Mia, Zepto as well. And where are we heading, actually? Frankly, a lot of introspection is required here. It's nothing but an expensive, silly device to cut the capsule, which is marketed as robotic surgery. Where is the robots here? I just can't understand. And when we come back, why we do is some basic human desire. We want to differentiate ourselves from the crowd. We want to prove that we are better. But sadly, to tell me that, you know, in the current stage of evolution of these devices, being not only they're expensive, but they're nothing less than a gimmick. I'm sure most of the surgeons world over have realized that. You can just check the sales figures of each of them and you come to know. I would conclude by saying that rexus is one of the only remaining art in our phaco surgery which is dependent on our skills. Rest of all, phaco, everything is mechanized. And there's no greater joy in doing these surgery. And you take away this, and there's nothing fun in doing surgeries. That's it. Thank you, sir, for attention.
Very good morning to all of you. Sorry that I was late. I was stuck in an emergency. Excellent presentation, Dr. Deepak, sir. I'd like to call upon Dr. Subhash Prasad to give his talk on Zepto in mature intumescent cataracts. So friends, today in this debatable debates, we are going to discuss a lot of such situations in our day-to-day practice where there are dilemmas as to which technology to use, what technique to use. So there are a lot of things that we can learn and take home, and we will have discussions. Let us complete each debate and then we can have discussion on it. Yes, sir, please.
Good morning, everyone. Dr. Deepak Magur told that he is junior to us, but I think he is much senior to us as far as these skills are concerned. So all respect to Dr. Deepak also, I would be talking on this Chote Mia. So you all know that The advancement in technology and the IOLs has made the cataract surgery no less than a refractive. It's not coming. It's not coming. So advancement in technology and IOLs has made cataract surgery no less than a refractive procedures, and each step requires perfection and precision. And capsulorhexis is one of the most crucial steps of phacoemulsification, and a proper sized and shaped and centered capsulorhexis or capsulotomy is quite essential to not only for the subsequent steps of the phaco, but also to have the lens in the perfect position and in the effective lens position. You can see there is the capsulorhexis, manual capsulorhexis done in some of the cases. Do you expect that you put multifocal IOLs in these patients? Never. And mature cataract with intumescence is always a challenging scenario in all of the most of the time, and not everyone is so talented or so I would say that skill that everyone get away through that. You can see this can have this much of this type of problem very often, but obviously there are various ways and means to counter that, but still it can. So there is no way to have a reproducible capsulorhexis, round capsulorhexis in these patients of mature intumescent cataract in many times. Femto, on the other hand, is known to have a very good precision in as far as capsulotomy is concerned, particularly in cataract which is not so mature in intumescent. But there are reports that there are chances of microadhesions in complete capsulotomy and sometimes anterior capsular tear also. And because of its large size and the need for eye docking and the various other things, it requires actually longer time and change in the surgical sequence also. And not only that, is very initial high cost, and the subsequent costs are so high that it's not possible to afford each and every one of us. On the other hand, Jepto is, you can say, is midway between the two, which is able to give precision almost 99% of the time, even in all types of cataract, even with the cataract with corneal opacity, and it requires very less time. It doesn't actually hamper the surgical sequence. This small video clip, this is my first case of Jepto, so I can proudly say that there is no learning curve associated with using Jepto, and you can use it in any type of cataract. Only thing is that it requires a little more expense on the part of the patient, and the capsulorhexis stage is very smooth. Even it's better than the better than the Femto, and capsulorhexis edges are even stronger than what we get in the Femto also. So if you compare all three procedures, Jepto scores almost all parameters. Jepto scores better than the others two. But definitely it requires more expense on the part of the surgeon and more on the part of the patients also. So Chote Mia definitely has a role in case of mature intumescent cataract. Thank you so much.
Thank you, Dr. Subhash Prasad, sir. I'd like to call upon Dr. Rohit Om Prakash, sir. He is an excellent surgeon, and also welcome to all our expert panels. And thank you so much for all our speakers and the delegates here for joining us today. Mature intumescent cataracts is something which we really dread, and each time we do it, we think we would probably end up having an Argentinian flag sign. And definitely, now let's see what sir has to say about flags.
Thank you, Dr. Anaga, for the opportunity. Well, trifles make perfection. In perfection is no trifles. So, Dr. Deepak Magur, sir, and Dr. Subhash, the idea is not to do things. The idea is to move forward and see whatever is the best. If I have to suggest intumescent cataract in my own eye, I would suggest get a Femto done. Let's understand what is happening. Well, there is a high intralenticular pressure with pressure gradient. There's a forward bulging of anterior capsule. Now, what happens when we create a nick? There's a sudden squirting of fluid with centrifugal force, and there is pressure from posterior compartment, which causes radialization. So this is what we have to realize is the thing. And what is the advantage of flax? It creates multiple, fast, circular perforations in a closed chamber. So mark each word and you will know the answer. Though there's a squirting of fluid from multiple points. So when you're creating all these things, multiple points, so there is no efflux of fluid suddenly from one point. Circular perforations, as Dr. Rajendra Prasad has shown in sewing needle, it doesn't extend. There may be incomplete, but that you can complete with using Tripen Blue guided CCC completion. This is a video to show, this volcanic eruption. This is slow because this was with the earlier LensX system. Now we can go as fast as 0.8 with the catalyst. I have no financial interest whatsoever. You can see once that is done, Tripen guided, and you can create a Rexis guided one, and see after this you will find how beautifully the fragmentation is there and makes phaco so simple, so easy that it's to be seen, to be believed. So no doubt, he was talking about strength. We don't have to fight. And you will see this is courtesy Dr. Sudhang Bharti, how strong. It is aptly strong. We don't need to wrestle around here. So Dr. Magur was showing the comparative evaluation of femtosecond laser by Dr. Titial. I would like to show what he has shown and what the results are. He says that femtosecond laser-assisted cataract surgery has the advantage of creating a circular and optimally sized capsulotomy in cases of white cataract. So it is definitely, as he has shown, it's definitely better. So flax advantage for capsulotomy, multiple, simultaneous, fast perforations with multiple points squirting of fluid, re-emphasize, fast circular perforations with minimal radialization, closed chamber, so there's no pressure gradient as it is there with the Zepto, Tripen blue guided completion when required. I think the choice is yours, what you have to decide.
Thank you, Dr. Rohit sir. Dr. Devashish, what is your take on this?
All the things have been very beautifully shown, but there's some dependence on technology which we can't avoid perhaps. But for the common man, I think Rexis remains the mainstay. But you should not compromise on viscoelastics. High molecular rate, like Helon 5 would be the best thing to go for, no financial interests. And then you can perhaps do it as good as the Zepto. Thank you.
Dr. Haldipurkar sir, you've been one of the pioneers in phacoemulsification. If it was your eye, what would you do?
Sir, please.
Please come.
Sir, please.
You should ask us difficult questions. If it's
Please
your
come.
eye or not.
I cannot go to that university.
Why it will go? Hey, it won't go. See, the only beautiful point that I liked from Megor, he said, there's one step, where you have a scope to really, feel glad that you can do it. And with all measures taken properly, I think intumescent is no issue for a Rexis because you can always decompress. Decompression is so easy. Meaning, with good viscoelastic, decompression is so easy. And well, Rohit, you showed it nicely. There's some fluid still behind, but
So that was Dr. Deepak Megur. So we are talking about a routine, a general average surgeon. And second question was in your eye.
Oh yeah,
Irrespective of the
First
cost.
question was if it was my eye.
So you would go to Dr.
I would
Deepak
go to
Megur.
some of these people sitting in front.
The problem is if it's a slightly smaller pupil, then it becomes a challenge. So neither flax nor Zepto would really help. Definitely, manual Rexis is something which all of us need to know and will always stand us in good stead. The question is, if you have access to a technology and if cost is not a factor, then what would you prefer? Sir, you wanted to say something?
What I do is, the closed eye, inject sodium hyaluronate in the eye from a small side port, fill it deep, and then take a 26 needle on a syringe. See that this
Absolutely, sir. Yes.
puncture in the center, dribble down, and be ready the moment you puncture to suck. You get a fraction of a drop of fluid from the intracapsular fluid, and the capsular bag becomes soft, then you exist.
Yes, absolutely.
Don't need flax, don't need anything.
I agree, sir. Closed chamber is the
N number of cases like this, it works brilliantly.
is the key, and one reason why flax works well is because it's really fast. It takes 1 to 1.5 seconds. I think on Catalyst platform it's one of the fastest. Yes, 0.8, so it's sub 1. So that is the reason why, and it is extremely fast. Even in Zepto for that matter, one advantage of Zepto is 360 degrees instantaneous. So anyways, that is something which will always, the debate will continue, and let's move on. Any?
Just one point. Sir.
Yes, sir.
And Dr. Rohitom Prakash, sir, your invention, this flap sign, you should not be worried about the Argentinian flag sign. Even if you have it, you know that it is when it is going to the posterior capsule. You know it for sure. So you should be confident. It's your invention.
Okay. I think Dr. Kumar sir wants to go for another thing. So we'll start with their talk. Young computer executive with cataract, what would you do? Edof versus trifocals. So in today's era of increased demand and increased expectations from our patients, multifocal is something which we all want to do, wish to give to our patients. Let's see what would be the lens of choice.
Good morning. So the actual debate is what will I have for my own eye? I really don't understand. I'm really shocked why there is a debate. Actually, it doesn't need to have a debate. But today we have synergy, trifocals. It basically means you're compromising the quality of vision. So we all understand that good vision is not only 20/20, it's even the quality. And we understand that if your patient gets a trifocal, you are giving him complementary free halos, glare, and poor contrast and poor image quality. And that's what he's always going to, these are images on the net, you know that this is what patients complain. And in case a patient develops a capsular phimosis, or it gets decentered and you have a trifocal inside, you're definitely in trouble. So trifocal basically means compromise in terms of quality of vision, and so an unhappy patient, and so an unhappy doctor. So in my own cataract, what will I prefer? So we all know that the IHANS or any Edof lens is a refractive technology. There are no rings, there are no zones, it's a single piece, there is no learning curve. We also know that it also has improved intermediate vision. There is no dysphotopsia, it is a good quality of vision and an excellent contrast. The contrast is as good as a Technis 1 IOL, which is excellent. So for the choice here, 4 months back, yes, I had a patient post-refractive. I was using Symphony IOL and doing micromonovision. But patients, even with a Symphony IOL, complained of 2 rings. The patients with trifocal IOLs complained of many rings. Till now, I have used lots of Symphony IOLs in post-refractive cases, and patients are happy, but there is a loss of contrast. They do complain of halos, and so I shifted to IHANS for a mix and match. Seeing is believing. This is a very old slide. I've done many, many more cases now, and see the end result, excellent quality of vision. So trifocal basically means poor quality. Studies done in 2019, more studies done. It also says that patient needs to learn and have neural adaptation. Why you want to struggle with the brain of the patient? So if the patient doesn't adapt, the patient is going to be unhappy. So multifocal IOLs, there are lots of studies with multiple varieties like the fine physiol IOL, the trifocal acrylisa, name it, and the patients are unhappy with the quality of vision. And that's the reason why some patients who remain dissatisfied, it can even go to the level of explantation. In summary, who wants night driving problems? Who wants contrast loss? Complementary glare, halos, and starburst. And if it decenters, you have to explant. Remember, if you explant, reimplantation and bad luck if something happens. So friends, senior, there is no confusion here. Why would you select something so bad? As far as I'm concerned, I'm completely sorted. If I have IHANS for my eye, examining patients, we are sorted. Seeing movies on the iPad, we are sorted. Mobile, no glasses. Emails, no glasses. WhatsApp, no glasses. Photography, eating, music, instruments, no glasses. Driving, no glasses. You won't see halos, there is nothing. See the operation trolley at the same time. You can look into the microscope at the same time. You don't need glasses. And if there is a 3D microscope, okay, the future is everyone talking of 3D, you won't need glasses. So when I'm willing to wear glasses, yes, I do agree that they do need a little ad, but the ad is about 1.25 or 1.5 to read a paper, which I hardly do 30 minutes in a day, and that also I have stopped now. So mind you, friends, I don't think there is a debate. There is no difference, there is no choice if you had to do it for your own eye. Thank you very much. Yeah. No.
Excellent presentation, Dr. Kumar. Today we are spoiled for choice as to what lens we should use. So we have an array of lenses that we have today with different principles of how we can give multifocality to the patient. And trifocals is one more option. So Dr. V.C. Mehta will enlighten us on this.
Good morning, everybody, and good morning especially to Dr. Kumar. Please get up. Your slides are very old. All the halos and glare are of the past, not of the present. So, a young computer executive with cataract, whether Edof or trifocal. My dear friend has opted for an Edof lens. Obviously, a complete preoperative workup will be done, and if the patient is found to be suitable, then my choice would be a trifocal, because the visual needs of a computer executive is not just the intermediate vision. Quite often, they shuffle between the computer and the mobile. And therefore, you cannot ignore the fact that near vision is equally important as much as the intermediate vision. My dear friend has conveniently left out the fact that to read N6, you need plus 1.5, and you subtly addressed it without most of the people realizing that. So my choice is trifocal because it gives distance, intermediate, and near vision. I don't know why you don't choose a trifocal lens. Is it because are you afraid of halos and glare? To remind you that the occurrences of dysphotopsia with the trifocal lenses is significantly low in one of the series of the lenses, and I'm sure most of you people would also be having the similar kind of thing, provided here is that you select your patient well and you achieve exact emmetropia. If you are left with certain amount of refractive error, you are bound to get some kind of a dysphotopsia. So dysphotopsia is not really happening in the present lot of trifocal lenses. It was there in the previous years when you had a Restore Plus 3 and all those lenses. And even the contrast vision is very good. Both the photopic and scotopic visions are not affected much in the present day trifocal IOLs. Edof does not give you a full range of vision, Dr. Kumar, and what you miss out is there's something is missing out. There's definitely something which is missing out, and that missing out point can only be completed by the trifocal lenses, which gives you a full range of vision. And remember one thing, Kumar, remember one thing, and that is you are missing out on N6, and that is what the patient wants. Thank you.
That was a superb presentation, Dr. V.C. Mehta, sir. So the fight continues, trifocals versus Edof. Dr. Anurag Mishra, welcome to the debate, and your comment, please.
So
this was on Edof versus trifocal in a young computer executive.
Yeah, so comparing the two platforms coming in from arguably the #1 IOL manufacturer in the world, I've had experiences. They do stand out exactly as points put forward by, I'm sure, both of the, I missed a large segment of that though. However, there is just one thing that I would like to bring to the notice of the esteemed house here. To my experience, the Edof in 1 in 50 patients, and in particular, and I found this to be essentially in the less than 40 age group, does behave just like a monofocal. It does not give you anything even for intermediate. I have found this in 2 of my patients, and I was a little surprised. I have noted it to the company as well. So I had to choose a trifocal for the other eye when the patients came in. So, and so that's the reason why the reasons are known to me, the reasons are known to them as well. So we just need to be careful about that 1 in 50 possibility of this behaving like a monofocal.
So I think each patient is different. We need to cater to the needs of the patient. A patient would probably, what we are talking here is a young patient, a patient who needs computer work. So it's a very specific scenario. So in such patients, what they need is basically intermediate vision. Yes, he may be driving because he's young. Yes, he may be also looking at his mobile where you use more of near vision. So today mobiles make a very important part of our lifestyle. So I think in today's scenario, no matter what the patient says, it is good distance vision, good intermediate vision, as well as good near vision that we all need to give. Glare and halos is something which is now probably much lesser compared to the older yesteryears. And with the Edof lenses, definitely I think they have improved. Dr. Haldipurkar sir, in your experience, which of the various Edof lenses, so we have no financial interest whatsoever, all of us. So which Edof lens would you prefer and would you think gives the minimum glare in halos?
Well, I think those the Proxa,
The
Mini-well
mini-well, yes.
Mini-well, that
Sifi.
probably is a good lens, but my personal practice is very minimal on that based on VBT, and VBT I found to be extremely satisfying.
Yeah.
Except that
Yes, sir.
it may not take you here, but Proxa can do it.
Proxa, because it's the other eye which gives you
Proxa
near
has
vision.
3
Yeah.
zones instead of 2.
5
so that's
zones.
5 zones, yeah.
The
5
mini-well
zones.
has 3 zones, the Proxa has 5 zones. Yes, yes, yeah.
My practice for these trifocals has been very limited because I'm very conservative about it. But nevertheless, in the last 6 months or so, 4 months, I have tried VVT, no financial interest whatsoever, in compulsive night vision in young adults also. And the results are more than expected.
Hands down.
Yes.
Absolutely, sir.
Absolutely.
Dr. Boramani, sir, you wanted to say something?
There is a new lens, the research of Dr. R.C. Shah and Dr. Jagdeep Kakadia, autofocus lens. This is a polyfocal lens in a true sense. All our multifocal, trifocals are either bifocal or trifocal. But this Dr. R.C. Shah's research is a true progressive intraocular lens, and it is independent of pupil size, independent of angle kappa. You can put it in diabetes also, and whatever compromise you are having for near vision in the Edof, that is also not required. It gives a full range of vision, and if you hold the lens against light, it looks like a monofocal. There are no rings. There are no rings in the lens. And you mind my words, mostly all of us are going to put these type of lenses
So,
in future.
yeah, you're very right. So, the diffractive platform basically cuts off 18 to 20% of the light because of, and gives rise to glare and halos. Things like mini-well work on the principle of spherical aberrations, and there are no rings, and probably that is why the glare and halos is less. Yes, sir.
No, I was going to say the same thing as Jagannath said. Same thing. Even I'm using those lenses. Excellent. Excellent. I think
Yeah.
probably, as he said, the future is going to be that lens.
Thank you.
Jagannath is there, Dr. Sao's here. All of us are using it. It's fantastic.
Just one point to make it, at least a mix and match, I think, is the best option, because whatever you do, as madam said, it cuts on some say 18%, even if it is 10%, you miss out on a little bit of contrast sensitivity. Well, I don't want to, experience needs to be done, it has to be put on horizontally. It cannot you just, and no, there's no toric option also as of now. Anyway, it needs to be seen.
We need to see, yeah. So let's move on to the next debate. It's on brown cataract, SICS versus phaco versus flax. So I'd like to invite Dr. Jagannath Boramani, sir. He's a pioneer in SICS, and he also has done a lot of work on managing astigmatism with SICS. So let's see what he has to say.
Yeah, thank you, Dr. Anga, for inviting me here. But you didn't tell me, when you called me, you are going to talk on brown cataract. I was very happy. And you didn't tell me who was my opponent. Fortunately or unfortunately, my opponent turned out to be my mentor and teacher in phacoemulsification, the Bhishma Pitamaha of phacoemulsification, who has held my hands and taught me phacoemulsification. So I'm literally having feeling like Arjuna on Kurukshetra. But everything is fair in love and war. So let me start. I have gone through the literature search. All the papers say that phacoemulsification and SICS gives equivalent result. Most of the papers are saying, some papers are saying that the central corneal thickness increases after the phacoemulsification. It doesn't increase with SICS. SICS is more useful for intumescent and hard cataracts, and generally, as far as the economics is concerned, SICS is useful for our Indian scenario and the common man. In the previous debate also, Dr. Anga was telling about think of common man, think of common man. So let us think of common man. The flax option, even if hypothetically, if all of us are convinced that flax is the surgery for brown cataract, I don't know how many of you are going to buy and book a flax, the femto machine within say 6 months here afterwards. And the most important thing is that SICS is eco-friendly. The carbon footprint is very high in phaco and flax. Only problem is that all the published literature says that what about astigmatism, because SICS, as per the published literature, increases the astigmatism induced is little higher. But that also is not true if you learn an advanced SICS. I can show you few cases wherein I have done brown cataract multifocal lenses and astigmatism is not induced at all. There are so many cases, 0.33, no change. This is a case 0.44, it has been brought down to 0.07. And even if in cases of higher astigmatism, this is a case of high astigmatism, couldn't afford toric lens, still I have brought it down only with SICS and only with the scleral incisions. So I am putting the multifocals and all these autofocus lenses with more confidence because I know how my astigmatism is going to be controlled. This is a doctor patient who wanted multifocal without toric. With multifocal, I brought down his astigmatism. Now, how this is achieved, the principle is very simple. You know that if you make the incision from curved, the astigmatism is reduced. But why not make it more and more curved if you want to induce very less astigmatism? So I am promoting this as a premium surgery. My data has been gone to IJO and most probably it will be published, hopefully. So I publish SICS as a premium surgery with or without premium lenses. My SICS packages are higher than the phacosurgeon charges surrounding me. And mind you, even if we should not talk about the finances in academic session, the highest package for cataract in India is for a monofocal lens with SICS, and that is 2 lakh, which is going to be 3 lakhs in very near future. So now the question is, in all the conferences you have already heard, when to convert to SICS in difficult phaco, when to convert. Have you heard any talk? Mostly not. When to convert to phaco in case of a difficult SICS? Keep thinking. There is no such talk. This means that SICS is for all soft and hard, white or brown, rich and poor. It is for rural, urban, beginners and everyone. Learn advanced SICS and promote it as a premium surgery. Instead of paying to the companies, you earn yourself. So do premium surgery, earn well and sleep well. Thank you very much.
That was an excellent presentation, Dr. Goramani, sir. So now I'd like to invite the king of phacoemulsification, Dr. Haldipurkar, sir. Basically, brown cataract. So what the scenario that we have here is a hard brown cataract, say a grade 4, 5, 6, I would say, where there are so many other issues. It's not just the hardness of the cataract. There could be the zonules that are weak, and using phacoemulsification could be a little challenging. So who better can tell us about this than the king of phacoemulsification?
Thank you, Anaga. I start with a lot of compliments, and I thank Jagannath for nice words. But let's not take that common man approach here. It's a very scientific discussion. What exactly, which procedures is placed where? So let's not get swayed by that. So one thing we should remember, with all due respects to Jagannath, who's an excellent SICS surgeon, and probably if we had not adopted to phaco, even we would be as good as him in phaco, in SICS. So any technology taken to its perfection will deliver results as good or better than others. Here I'm talking about 3 techniques: SICS, phaco, and flex. See, we have to understand one thing. There was a distinct reason why we moved from SICS to phaco. We wanted to reduce the incision size. We wanted to decrease the tissue cutting. We wanted to cut down on the induced corneal aberrations and spare the conjunctiva. And what happened? We achieved all that by going into phaco. Then we ventured into flex because we wanted more round rexes. We wanted better incisions, better positioning of the lens, and pre-cut nuclear pieces. Yes, of course, we got all of that. But a reasonably good phaco surgeon almost achieves all of that most of the times. So that means it is, see, one transition was definitely for something which SICS would not have given you. Another was only kind of refining things for a lazy surgeon. But someone who is good enough, he can achieve most of that. And then when we talk of brown cataract doesn't come like on a platter. Sometimes it comes with all these. And all these things come, you have to resort, go back to your technique of phaco. And when you go through all the research, and there are plenty of studies, thousands of patients have been screened. In extensive literature research, it is very clear. No statistically significant difference was detected between LCS and manual phaco, in uncorrected distal visual acuity, corrected visual acuity, and total surgical time. And there was no statistically significant difference in the incidence of overall complications. Another study talks of primary visual and refractive outcomes where there was no statistically significant difference. In terms of secondary surgical ends, there was a statistically significant difference in favor of flex over MCS for effective phacoemulsification time, capsulotomy circularity, and postoperative central corneal thickness. But there was no statistically significant difference in the long run. And there was no statistically higher concentration, and of course there was significantly higher concentration of prostaglandin after flex compared to this. Again, in terms of corrected distant visual acuity, uncorrected distal visual acuity, at long term, the difference was not very significant. So when you go through all these, again, they talk of safety index, which was 1.777 in flex group and 1.744 in CPCS, which is cataract phaco, showing higher degree of safety in both the measures. So if you go through most of these studies, well, the flex is definitely good for a normal case, but when it comes to some difficult cases where even flex cannot be done, where you need to have some intervention for the pupil or for adjusting the eye to see things better, you obviously start wondering whether does it have any additional advantage. Now they talk of prostaglandin E2 levels, which are definitely higher in femtosecond assisted group, more than 10-fold the concentration of PGE2 in the control group, which was 17.3. And once the prostaglandin is released, it causes, it's released from non-pigmented epithelium ciliary body. It causes intraop-miosis. And sometimes in a difficult cataract, if you have an intraoperative miosis, I'm sure the flex surgeon will say it doesn't happen, but it's been shown. It also causes mild iritis, increased cells and proteins in the anterior chamber. So, if all of this happens, as of today, the return on investment to the doctor and to the patient is not fully convincing, but I may be wrong. But I'm completely happy with the outcomes of conventional phaco. So I rest my case, Your Honor. Thank you.
Thank you so much, sir. Dr. Aldipurkar, sir. Excellent presentation, as always. And yes, there are pros and cons of every procedure. Flax today gives us an added advantage. Let's see how Dr. Shrish Kumar presents his case. Now, in cases of brown cataract specifically, I don't know whether all those literature search that we had was specifically for brown cataract or for a routine cataract. Yes, the indications of using flax could be limited in our scenarios. Let's see in this case what Dr. Shrish. So inviting Dr. Shrish Kumar, is a dynamic surgeon from the Eye Foundation, Coimbatore.
Thanks, Dr. Anaga, for the opportunity. And of course, it's very difficult to contradict the statements made by the kings and pioneers in SICS and phacoemulsification. So I just want to prove my point of flax for brown cataract. We all know, the cataract cases like this, brown to black cataract or a brown cataract, it's a nightmare for many of the phaco surgeons, especially the budding phaco surgeons, for obvious reasons. This is what you can expect in many of the cases if it is not done properly, if you have not taken proper precautions. And don't be a fool, use proper tool. If you have a tool, definitely you try to use it. And quality is everyone's responsibility. We have to give good quality to the patient. So if the patient can afford, definitely you have to give a good quality surgery. And if you see here, this is a brown cataract. You can see a nice rexis being done by the femto. And nice segmentation has happened, and it's just you just have to separate these segments and just emulsify it. It's easy. Life is easy, and if the patient can afford, definitely you can give this particular benefit to the patient. And you just have to identify the cleavage line of the femtolaser and impale your phaco tip And just with the help of a second instrument, we just have to separate it. It's just a lateral separation you are doing. So you are saving so much on the phaco energy. Here, for this particular step, you have used only two. This is the CD. And you just emulsify each segments one by one. And at the end of it, the surgery is over. It's just 10 is the CD here. You would have used 30, 35 if you have gone ahead with the co-emulsification without femto laser. So at the end of it, you see a crystal clear cornea. The wound is so clear here. There is no wound burns as such. So this is what is needed for a patient. There are various publications on this. Fully tailored fragmentation is possible, adjustable grid size, energy pulse, and horizontal and vertical spot spacing can be done depending on the different grading of the cataract. And flag system allows for a dense grid pattern which can further reduce the effective phaco time, which can reduce 86% of your phaco time. And high quality fragmentation has significant benefits in very dense cataracts like this, what I have shown here. So it has made life easy. If you have the facility, definitely you can use it. Jagannath Boramani sir is a pioneer in SICS. He has taken out a nucleus, such a large brown to black cataract. But of course, like I don't say that it is his surgery, but it can be expected, and you can see the cornea on day one. The king of phacoemulsification, one of the best phaco surgeon internationally, Dr. Suhas. I have a lot of regards for sir. But it can happen to him. This is the first day post-operative picture. There is hardly any endothelial cells. So, but flax is the best, like the preoperative, the nice glistening specular microscopic count of around 2,700 cells. Post-operatively, day one, you have a crystal clear cornea, and cell count is just 10% less than the preoperative level. So, I just want to conclude my talk. Technology is closing the gap between what one can imagine and one can do. So if you have the technology, use it to complement your technique to give the best to your patients. Thank you very much.
Thank you so much, Dr. Shrish Kumar. That was very well said. Okay, so coming to the point, agreed that each case is going to be different. Now let us divide it into two parts. So there are two basic critical parts. First is the capsular access and second is the nucleus management. So I would like to ask Dr. Anurag Mishra and Dr. V.C. Mehta, sir. Dr. Anurag, considering it was a patient who was an 85-year-old patient with a dense brown cataract, assuming you have access to all the technologies and cost is not an issue, what would be your procedure of choice? Now I am speaking in terms of the capsulotomy, and I would ask Dr. V.C. Mehta, sir, in terms of nucleus management.
See, flax for me is a technocrat's fun. It's a lot of fun to work with that machine. I enjoy more than even the CCC and the nucleotomy. I enjoy making corneal incisions with that. I make all my ICL incisions, which are 3 millimeters, and they give me an SI of around 0.1, which is fantastic. Since you mentioned the age of the patient, 85 years, I would definitely look at the endothelial status, because mind you, when we're using phaco energy, however large or big it may be in size, but we're using under the cover of viscoelastic. When we're using the flax energy, we are doing it without any cover of viscoelastic to protect the endothelium. So if you're going deep down producing this grid pattern, it is going to consume 1.9 millijoules, and staying in the eye for around 23 to 25 seconds, it's going to produce heat. So the endothelial status has to be looked at. For a brown cataract, asking me personally, I would do the corneal profile and the CCC, I mean the rhexis. I would stay away from nucleotomy. I would leave the nucleotomy part to the phacoemulsification part, the phacoemulsification part of the procedure.
Sir, sir, please come here. Sir.
I think the damaging part to the endothelium is the energy dissipated from the ultrasound. It's not from the femto, femto part. So you saw the case, only 10 EPT. I mean, that's unbelievable for a hard brown cataract. That's what you want. The maximum energy is spent in the phaco in taking out all the pieces, not in making all the pieces. It's the quadrant removal where it takes. And talking about the endothelium protection with the viscoelastic, when you are working on a hard brown cataract, you are working on a very high vacuum. So it's very quickly the viscoelastic comes up. So unless you top it up, in a brown cataract, I top it up at least 3 times in order to protect the endothelium. So if you look at the terms of the damaging factors, then the pre-treatment with the femto definitely reduces the amount of energy that you spend with an ultrasound in the eye, and that's very important.
Yeah, exactly. So in this case, what we are trying to say is, in a hard brown cataract, capsulotomy probably could be done either with manual or with the flax. But what is more important here is how you are reducing the energy by making the nuclear fragmentation and the choice that you get of nuclear softening also in many of our newer machines. Now, in these patients, also in the experience, Dr. Nagwekar, you have been using flax for a lot of time. Many times people say in such a hard brown cataract, does the femtosecond actually penetrate? Like for example, in white cataracts, it may not actually give us so much of an advantage. In hard brown cataracts, what has been your experience? Does it really make a difference, or does it not penetrate at all?
The penetration of the flax is dependent upon the opacification of the nucleus. So if you have a white cataract, there would be hardly any penetration. But if there is a brown cataract, and if the fundus can be visualized preoperatively, I mean, visualize means you can get a good glow. There is some transparency, however brown it is. That is the reason why on an optical biometer, you are able to get the actual length of the eye, even in a hard brown cataract.
Right.
So it being a light source, you have to depend upon the opacification of the capsule and the nucleus. So if it penetrates, it gives you. And once a plane of cleavage is created, all you need to do is get into that plane, and then the separation, as Dr. Shri showed, was very easy. So I don't think, and another thing, Anurag, maybe what you said is right, but remember that the capsule does not detach itself and float in the anterior chamber. So I don't know how much of energy is being transmitted to the endothelium because of the build of heat.
There are reports, and my experience also have seen that, and there is a non-resolving corneal edema, particularly incision or para-incision, and it stays for some time, particularly in those patients who have got low endothelial cell count. So that's the reason why it might not be damaging, but I just want to be on my watch, so any which way if the patient's going inside. But I agree with you completely. It gives us an excellent template, and the division and the fractionation of the nuclear fragments is excellent brown cataracts. But Anaga, I think after the post-debate discussion has been all about flax v phaco, does that mean that SICS emerges out as the clear winner?
Actually, I was about to come to it. So I think to sum up, the message that we need to give across is do what works well and what works best in your hands. There is no ego issue here regarding flax or phaco or SICS. Finally, at the end of the day, we want to give good vision and a clear cornea on the next day to the patient. So on table, and each case is going to be different. No matter what we discuss here, on table, if you feel that there are some ligaments that are, zonules that are weak, or if you feel that the pupil is coming down, there are so many things that we may need to change. You may have done flax and then you need to convert to SICS also. There have been situations like that. So finally, at the end of the day, we have to do a good workup. Like he said, probably a specular is important in these, more important in these patients. A good counseling of the patient that you may need to convert also. And you need to be very proficient in your manual phaco as well as in SICS. And if you have access, definitely why not flax? So, yes.
To the question that you asked about 85-year-old with the hardbound, sometimes you may be inclined to go for an SICS.
Absolutely. Absolutely.
So
that was what I wanted.
That is what my point was. Since we were, after the post-debate discussion was flax v phaco, does SICS emerge as the clear winner?
Absolutely.
So we are not debating it. We are not even debating.
Fine. So let's move on to the next debate. And here, this debate would be on a small pupil. What would be the pupillary expander of choice? The BHEX versus the iris retractors. आगे नहीं जा रहा है? थोड़ा चेक करिए. Yeah, okay. So the BHEX is basically innovation of our very own Dr. Suven Bhattacharya ji. Just to tell you all about what it is, it's a very thin profiled, very gentle expander, okay, around 0.075 millimeters. It's gentle yet firm. So what do we want? We want to keep the pupil at bay. We don't want the pupil to come down on you when you're operating. So what does it have? It has 6 notches which engage the pupil and 6 flanges. 3 of them go above the iris and 3 of them go below the iris. So now let's see how it works. So this is a patient. So here you can use a 23 gauge microforceps which you're putting in through the main port. You can also put in through the side port, and the 2 side flanges you're using either a Sinskey hook or the 23 gauge forceps and using the side port. So look at how good the adequate kind of opening that you are getting. So all your procedures you can continue extremely easily as if there has been just a well dilated pupil. Each and every step of the phacoemulsification can be carried out extremely easily, and look at how easily you can remove it. So you just have to hold on to it, disentangle it from the, disengage it from the pupillary edge, and then you can remove it, even through the side port. And this is a first day post-op, 6/6, and you can see that the pupil has not even, you feel it's not even been touched. Now this was a floppy iris, and the BHEX also works very well here. Now we all know in a floppy iris there is going to be a lot of floppiness, a recurrent iris prolapse. As you can see, even a mild hydrodissection, the iris tends to keep prolapsing. In these cases, yes, iris retractors can be used, but what is more important is you should not touch or you should not irritate the iris more. So here you're gently disengaging it from the pupillary edge and then removing it. And this is 6 hours post-op. Patient is doing extremely well. Now in iris hooks, what are the downside? Multiple incisions. Already you have 2 side ports, already you have 1 main port, and you make 4 more ports, which is no need at all. It's more time consuming. Who has the time to make 1, 2, 3, 4, 5, 6, 7 incisions and then remove them at the end of it? And this is what finally you get, because many times you tend to pull so much that you can cause sphincter tears, and this can be how it looks like. Yes, where to insert, that's a very, very important decision. You insert it too high and the iris will be pulled up towards the cornea. You insert it too low and it will be all bunched up towards the edge, and the phaco, when you're putting it, it will keep scraping against the iris, which irritates it more. So you need to get that sweet spot as to where exactly to make those incisions for the iris hooks. How much to pull is very important. You pull too less and you have a small opening. You pull too more and you damage the sphincter. All these problems are negated in case of the BHEX. Now in a difficult situation, so this was a patient where I thought it's a mid-dilated pupil, I can go ahead without any pupillary expander, and look at what happens. Even before the hydrodissection is done, the pupil is coming down, as if I've put pilocarpine. I tried to put in epitrate, I tried to put in phenocaine plus, but nothing worked. Now, if we had used an iris retractor in this scenario, definitely I would have also pulled on to the capsular rim. But here, the BHEX works very well because it's so gentle and you can do it under good visibility and very, very easily. Definitely, there could be a small learning curve, but it works so well. Look at the ease with which the BHEX can be removed, and look at the pupillary edge. It's absolutely pristine. Even in cases like this, in a very small pupil, yes, if it's a very difficult case, people have used Mulligan rings also, but why not our own simple BHEX? Yes, if it's a very small pupil, you may need to do a little pupillary stretching here before you go in for the BHEX, but yes, it works extremely well. This was another case where a femto was done and then the pupil came down. Yes, in flax, sometimes there is a prostaglandin release and the pupil may come down, but there's no issue at all. We can go ahead with the BHEX. in these cases also, so the capsulotomy was not even touched. Now we are removing the capsular flap, going ahead with the hydrodissection, and this was a multifocal lens. So we thought that the pupil, the capsulotomy size was a slightly lesser, so we have now extended it, and now we are removing the B-hex. So look at the pupillary edge, it's absolutely pristine. So even if you compare it with the Malugan ring, you get a good 5.5 millimeter opening, which is absolutely enough for all your phaco maneuvers. It's an extremely thin profile, uniplanar, which is its biggest advantage, and it's jointless and extremely economical in today's scenario for all of us who would want a Malugan ring and charge so much from the patient. Yes, so to conclude, in today's world of increased expectations and use of premium lenses, we definitely can use such devices and then give good visual outcomes to our patients. So the BX expander is truly the Lord of the Rings, and it will make small beautiful. Thank you so much. So I'd like to call upon Dr. Saurabh Patwardhan for his talk on iris retractors.
Nitinol. It's nitinol. Thank you so much for the invitation to participate in this nice debate. And I'll be speaking about why iris hooks are better. And my job has been done quite easy by my competitor. And this is the competition, B-hex man versus the iris hook man. Let's see who wins. So this is the iris hook man, you know. It's nowadays we go to shops. The slideshow is running on its own. Okay, anyway. So nowadays we go to a shop and, we are shopping for T-shirts, anything, and it comes in different sizes. You know, we have, because consumer is the king. B-hex, one size, only one size, okay? And then some surgeons feel, the shirt is undersized. So the consumer is not happy. So there are different ways to use iris hooks. You can stretch as much as you want. You can stretch focally, only in some areas where you want to, see better. You can put it, little smaller, like she was showing some complication. That was because of wrong use of iris hooks and not the right use of iris hooks. So retract where you want. You have a lot of complicated cases, adherent glaucoma. You can just retract the iris. You can't use B-hex in these cases. You want to put a CT segment in particular area where the lens, is subluxated. B-hex is not possible in such cases. This is the case, adherent glaucoma, mother of an ophthalmologist. I'm not going to use B-hex definitely. In this case, I can just retract it with just 2 iris hooks and complete the case. Can B-hex do this? No. Okay, sorry. Iris hooks can also be used for supporting the bag. Okay, I'm not talking about B-hex here. I'm just talking about the iris hooks. It can support the bag. B-hex? No, can't do. IOL insertion. Now, ma'am showed quite good cases of, how it helps. But look at this. When you are doing IOL insertion and you have B-hex inside, the trailing haptic can just drag the B-hex inside and it's a lot of trouble. Plate haptics, you have to be very, very careful if you are using B-hex, okay? You remove the B-hex, you put the IOL in, and then if you want to expand, you can put it again. So be aware, there are a lot of complications if you are using the, the IOL drags the B-hex inside the eye. Okay, so B-hex didn't talk about this. Rigid pupil. So you cannot put B-hex in a very rigid pupil, You have to literally stretch it, okay? Otherwise you are stuck. You have to pull out the B-hex, you stretch it, you pull it, put it back again. Long struggle. But iris hooks can do it easily, stretch. SICS, most important surgery, I think more than 2/3 in India do SICS. Can you use B-hex in SICS? No. It will just come out when you want to deliver or you want to take the nucleus out. You can only use iris hooks. So my only question to B-hex man is, can you do all these things? And if I go to OT and my assistant tells, sir, there is no B-hex in the OT, I'm fine with it. When my assistant tells there is no iris retractors, no, I tell him just get the iris retractors in. Thank you so much.
Thank you, Dr. Saurabh. Dr. Anurag, now let's see what is your opinion.
Very nicely made slide, Saurabh. Absolutely stunning. But yeah, I mean, I agree with you that rigid pupils do not dilate very well with BHEX, and it has to be mechanically stretched before you put it in. Since the debate is between iris hooks and BHEX in particular, I'm not mentioning about the other expanders which even do a better job. But since the debate is about handling small pupils alone and not the adherent leukomas or other situations, I would just say that the iris retractors are likely to produce these microsphincter tears a little more frequently than any expander per se, because they render a more circular pupil, so the microsphincter tears are less.
One question. Dr. Deepak, please. So in your opinion, suppose there is a case of a dense brown cataract. So if it's a soft cataract versus a dense brown cataract and you have a small pupil, would your choice of pupil expander change?
Certainly.
I don't think so. I've managed quite dense cataracts with BX rings as well. Only the decision would change when there is a zonular health issue or there is an issue with the rhexis. I'm not sure whether rhexis is complete or not. These are the situations where I would definitely, you want a wider expansion view. These are situations where definitely iris hooks has a role in me. If everything is perfect, if I've got a good rhexis and everything is fine, I don't change the pupil expansion device purely because based on the density of the nucleus.
So let's talk only science now. The debate apart. Now, in case of iris hooks, like you said, if you want greater visualization, now what is the sweet spot? Do you actually take it to the limbus, or you just take it up to, say, 5 millimeters? What is exactly?
No, yeah, absolutely, you're
what
right.
is just for the benefit of the delegates, what is the ideal, how much do you pull? And where do you put in your incisions for the iris retractors? So these are two things I think we should make very clear so that there is no confusion at all.
I think that's an excellent question. The first question is about the placement of the incisions. They have to be behind the limbus, in fact slightly scleral. The length of the incision has to be short. They should not be long. It will be less traumatic to introduce. And
Should it be a tunnel or it should be a direct stab incision?
It should be a tunnel, but with a very small
So if there is a
valve,
longer tunnel, there could be difficulty.
It will a lot of trauma to the endothelium and putting in and putting out. If you're putting more corneal, the tenting up of the iris is an issue which can result in iris chafing. That's an issue. So where you place is important. And of course, you can manage with 4 hooks or 5 hooks based on your personal preference. I prefer to use only 4 rings. The trick here is to use the 2-1 very adjacent to the main incision. That is what prevents the iris from coming out. And
Even in the shape, do you prefer a rhomboid or a rectangle or what?
No, if you're using,
I'm using 4 hooks, so I'm using only 4 hooks, so it just becomes a...
But what he's saying is, of the rectangle, the proximal limb is a shorter limb than the distal.
So the placement, should it be equidistant on all the sides? And compared to the main incision, how far from the main incision?
Yeah. So
and how do you plan in your incision? See, many times you first take the main incision and then you put in your side ports, or you make those side ports and then see, because if you've already made your side ports and then you want the incision is not for your comfort, then your entire surgery becomes a little
So usually the main incisions are created and then you plan the incisions for the iris hooks. Now regarding the second question, how much would you want to stretch? I think it's important for us to realize that we need to be as traumatic as possible, and the trick here is to not to pull it can go up to the limbus, but you have a very ugly pupil and loss of sphincter function the next day. So ensure that it is not more than 5.5 and 6. In very rare situations where you have an issue like rhexis has gone off or you have a peripheral posterior capsular tear, those are situations where you would be forced to use these.
And if you have a patient with a multifocal IOL, with a small pupil, would you do, what would you use in this case? What would be your
that should not be
expander of choice? Retractors or BX?
Most situations it would be just BX because it is pupil friendly. Unless these
So you agree that it's more pupil friendly?
Yeah, of course, definitely.
Everybody would agree. Even Saurav would agree.
Yes. Yeah, debate apart, yes.
Iris hooks, the sphincter tears are caused more when the pupil is more rigid. So if if you have like a floppy iris, you will never have sphincter tears because you are just, stretching
It's
the
stretching.
stretchable pupil. In case the pupil is quite fibrotic, you have to be very careful not to go beyond 5.5 mm. That's why I showed in one slide that Dr. Lucan had showed that you can just put 4 mm, pupil size and do the surgery, and you can expand in the area where, during the trenching, or you can just expand that particular area during the surgery
And
to
in
avoid
floppy
sphincter.
iris, what would be your expander of choice?
BX. So,
Because a lot of people feel in floppy iris, BX doesn't work.
No,
No, it
actually it
works
is more
perfectly.
advantageous.
Yeah, Exactly. more-
Because it covers more surface area of the iris and holds it
Yeah.
well.
So that's what message that we wanted to get across. Thank you so much, Dr. Deepak. I'd like you to stay on if you're free, please, unless you have a talk. So let's go on with the next debate. Secondary IOL with no PC or anterior capsular rim support. What would we use? Iris claw versus SF IOL versus glued IOL. Dr. R.C. Shah, sir, please. So this is a scenario where you have had zonular dialysis, a rent on table, and you have not been able to even salvage the bag. So let's see, or a planned case. Let's see.
Thank you, Dr. Anaga. I don't think there is any debate in this because iris claw has been extremely well proved and most of the people are using this iris claw. This is one patient which is spherophakia with probably will not have any capsule behind. So you take the incision. नहीं है. So you take a small nick on the interior capsule. We have trained more than about 300 surgeons. I think most of the surgeons in India, especially in Mumbai, they are all doing this procedure because this is supposed to be the most simplest, least irritant post-operatively. Now, in case you have a problem, you can pull the iris and make it small. It is such a simple procedure for anybody, less traumatic. You do not disturb hold the lens completely. Do not hold halfway. Check the patency of the claw. Put it vertically because you need to put it from 5.5. The overall size is 8.25. Now we have trained most of the junior surgeons. For the first time, they are able to do it very nicely. Hold the iris, the claw lens, just lift up the lens and tuck it. You can do from the opposite side also the same procedures. Again, lift up the iris claw and just tuck it, and the procedure is complete. The 3-4 points which I want to tell you is that please remove the viscoelastic completely. If you leave the viscoelastic, there will be iritis and a lot of iris pigment will be deposited on the lens. Second thing is you have to do a proper vitrectomy. No vitreous should be there in the anterior chamber. Such a simple procedures anybody can learn. This is a savior of all the patients where you have an inadequate posterior capsule as compared to the scleral fixation which requires a lot of dissection. You traumatize the conjunctiva and the underlying lymphatics. The eye remains irritable for a very long time, and post-op retinal problems like CMEs are much more in scleral fixation as compared to the iris claw lens. That's okay, madam.
Thank you so much, sir. Thank you so much, sir. I'd like to invite Dr. Aditya Kelkar, and he would be speaking to us on how SF IOLs would work in cases of this vis-a-vis the glued IOL or the iris claw lenses.
Thank you, Dr. Anaga, for this opportunity. And indeed, it's a difficult task to present to you about my experience of SF IOL, especially when the pioneer, Dr. R.C. Shah, who is excellent in his iris claw lens procedures, and Dr. Naran, who is also excellent with her SFIL and lots of publications to support her experience too. So it's going to be a difficult debate. All right, so coming to
So how many of us in the audience are doing SFILs regularly? Can we please raise your hands? And glued IOLs? So it's going to be an eye-opener for all of us. And iris claw IOLs? Wow. I think we have a clear winner here already. So both of you have a very big task ahead of you. So I hope your presentation is working, otherwise we already have the verdict.
yeah, but I still, for the sake of formality, let me complete my presentation. I've come all the way. Anyway, so we know that it's a very simple technique to perform. Most of us are doing iris claw, including myself. But yes, there are issues with the iris claw IOL, like pupillary dilatation is hampered, difficulty in visualizing the fundus, corneal decompensation in some cases, pigment dispersion, iritis, raised intraocular pressure, and cystoid macular edema is one of the things that you should keep in mind when it comes to these patients. Also the glare and photophobia, because the pupil doesn't really contract well post-operatively. So to counter this, there is another technique which my colleague is going to talk about, and that's a glued IOL. And the problem with glued IOL, according to me, is that the haptics which are supposed to be inside the eye are now stretched out and they are lying outside the sclera, of course in a pocket, which is actually a modified Gabor-Shariat's tunnel. And the glue that we are using is not for holding the lens, it's only to support the two ends of the scleral pocket. So the whole idea of glued IOL is probably to increase the cost to the patient and not to support the lens. And in addition, this is what happens to the haptics. So without wasting much of a debate, I think debate time, I think we are back to future, or maybe it's back to suture. So I'll show you another simple way of doing this scleral fixated IOL, popularized by Dr. Canabrava. And I think if Dr. Priya hasn't spoiled my presentation here because she wants to win this debate, my video will play. So let's see. क्या पता नहीं कहाँ तक जा सकते हैं. Video supports me, but I think you have been very supportive to these staff members. I think they are definitely taking care of you. And still, you managed all this.
Dr. R.C. Shah sir will say by the time it starts, your claw would be inside the... So by the time it starts working, Dr. Aditya, if you could, by the time yeah, only the video, not from the presentation.
Because the file is working anyway.
No, from.
one is averse to having these threaded threads under the conjunctiva, you can also make a Hoffman's pocket and leave these flanged sutures inside. So with this, I think
Thank you so much, Dr. Aditya. I would like to call upon Dr. Priya Narang for her talk on the glued IOL. So we will have a question for all the three regarding the stability as well as the tilt of the lens. Dr. Deepak, you were asking him, yeah. Dr. Aditya, sorry.
You're using a foldable lens, right? Why did you use a big? Hi. I mean, was there any reason for you to make a big incision in this particular case? Nothing. This is one of the first ones I did. Achha, okay, fine.
Yes.
And the suture was 6-O-proline?
Good morning, ladies and gentlemen. So I'm supposed to defend myself right now. Well, I'm not going to show you anything, any technique or anything. I'm not going to talk bad about anybody. I'm just going to show you pure science. So the best thing about, now this is a general term, for any scleral fixation, the best thing about it is it's very close to the anatomical position of the lens, where it is actually meant to be. So we come across this. The second thing, what I'm trying to show you is, I'll show you what you don't see actually. Because when you're putting up a lens, not you, everybody, we all see it on the slit lamp on the post-op day and we are very happy with it. But I'll show you what your eyes don't see. So I'll show you something, the high frame per second recording. This is a recording at about 360 frames per second. Our normal eyes, they cannot see anything beyond 30 frames per second. So now here we go. I'll show you everything about secondary IOL fixation. So this is for the anterior chamber IOL. This is a high frame per second recording. It's a very well fixated IOL. There is no issue with the intraocular lens, but you see what's going on in the eye. With a slightest movement, the entire intraocular lens moves inside the eye. There is a pseudo-phacodonesis. If you see all these videos, you will never perform all these techniques again. This is what's going on. I'll move on to the next. Coming up to the iris fixation. Whether you fixate the claws, aage, piche, it is all same. It's with the iris. So this is what is there. You just see the amount of phacodonesis which is going on in the eye. Surgeons, mostly they become happy that, okay, my lens is in place, patient is in place. I mean, the patient is happy because you have put up the IOL and you have, on the contrary, you have also explained to the patient that, okay, it was a very complicated case and I did a very good thing for you. Coming up to the suture scleral fixation, have a look at this. A very well fixated intraocular lens, no problem with the lens at all. This is what is there in the eye. Eventually, these are the cases which will come to you after a few years. They are not going to come up in the immediate post-op period because the immediate post-op period is quite fine. But these patients will eventually come up with some issues coming up because this intraocular lens, the movement of the lens itself inside the eye will damage or it will interfere with the vitreous, and I think Dr. Aditya Kelkar, being a posterior segment surgeon, you would agree to it. You cannot deny this fact. Coming up to this, it's an intrascleral fixation. Now coming up to this, I would not defend only for the glued. Probably this would also go with the Yamane because these are intrascleral fixation techniques. There is no pseudo-phacodonesis seen in this patient, and I rest my case with this. Because this stays as it is. Even if the movement of the eye is there, there is no movement of the intraocular lens. And there is no way that we can deny this scientific aspect. Coming up to the complications, people say this is easy to do, I can come out within 2 minutes. I do this, because this, because this is that. There are problems with the haptics. These problems or complications, whatever you see with the surgical technique are all surgeon dependent. If you handle your haptics, you handle everything, you know how to externalize the haptics, there is no issue with the technique. The technique is not wrong. The glued the glue that is being used, it's just to seal it, to prevent the post-operative hypotonia. It's not for the fixation of the lens. The fixation of the lens comes up with the intrascleral tuck, which is done. So, dear surgeons, the only statement is that this is the right choice. Thank you so much.
Thank you so much, Dr. Priya. So we have two questions here. First question is, what about the stability and the tilt of the lens of all these three? Who would like to answer it? Dr. Aditya. This is the debate apart, okay? You can take this.
So with the 10-0 Prolene sutures, the sutured IOLs, I'm sure there has been some phacodonesis, but with the new thick suture, which is 6-0 Prolene, the lens movement is much less. I haven't seen any patient with phacodonesis particularly. Coming to a recent survey that we conducted across India, and we found that majority of the doctors who face on-table PC rent, where the capsular support is inadequate, they use the iris claw IOL. Majority of the doctors who have aphakia coming to them for secondary management, they use the SF IOL as the standard way of treatment. Whereas the anterior segment surgeons, most of them are doing the iris claw IOLs, whereas the retina surgeons tend to prefer the SF IOL technique. That's the survey findings which soon would be published in the IJO.
So how bulky is the knot, Dr. Aditya, and where do you leave it?
See, there is a tunnel that forms with the 27 gauge needle.
So you tuck
can
it in.
Just push that as like a knob goes inside the scleral tunnel.
But you don't make a flap there?
We don't make a flap. But you can if you are averse to putting that suture under the conjunctiva.
Yeah, it is like that, what Canabrava has described and what Dr. Aditya showed. He has, Canabrava, Sergio has done this for CTR implant, or for the CTR implant, Sionis ring implantation and
Yes.
other things. He uses the same method.
Because that also used to have issues with the 9 or the 10 Prolene. So if Gore-Tex is not available, this seems to be a very, it gives an idea.
Recommended for that.
Fine. So final take-home message for this round, Dr. Deepak, for an anterior segment surgeon, I believe most of us are anterior segment surgeons here, what would be the procedure of choice to conduct a safe surgery? Because already the situation is complicated. We don't want to complicate it more. So in such a situation, what would be your choice?
I think the opinion is almost unanimous. I think the critical factor is you need to take care of the vitreous properly. Once it is done, most of us were doing some scleral fixation because of the ease and the lack of complications you have noted. I think most of us are quite happy with the iris claw lens now.
Yes.
There's just one case example that I would like to bring forward. I think I completely agree with Dr. Priya. The movement that she showed of the iris claw IOL, I'm sure it was a post-vitrectomized eye. And post-vitrectomized eye, at times, I had one patient who was complaining of a very peculiar oscillopsia. He used to say that my images are moving. Then I saw that the iris is very tremulous, and it's also moving the IOL along with it. So yeah. So maybe in post-vitrectomized eyes, iris claw is possibly not the procedure of choice.
Thank you so much. And we would come to the last round of debate. So we have a case where there is a preoperative astigmatism of one diopter. So here, I have not mentioned whether it is ATR or WTR. Okay. Dr. Nagvekar, we would like to invite you for your talk.
So it doesn't matter whether it's ATR or WTR, because you can see over here that even if you have a half a diopter of cylinder or one diopter of cylinder, there is a degradation of the visual acuity. Now you're talking of a multifocal lens. You're talking of a lens where everything has to be precise. Can we afford to leave the astigmatism? I don't think there is any doubt in our mind. And especially in cases when we are implanting an aspheric multifocal lens, even more important to correct the astigmatism, because even a small amount of residual astigmatism will increase or magnify the effects of the higher order aberrations. Now, why I prefer this? Because toric IOLs are accurate, consistent, and predictable. The correction is permanent, and you can also manipulate the amount of residual astigmatism to your benefit. So in cases of multifocal IOL, I would prefer to slightly change the astigmatism from against the rule to with the rule, if necessary, because with passage of time, there is going to be a drift. Not so much in the other alternative technology, which is going to be debated. And the most important thing is that there is very minimal or no rotation with modern hydrophobic IOLs. I mean, here you have a case where you have a post-op photograph which was 1 month post-op, And you can see the same thing, 27 months post-op, there is no change. And my worthy opponent himself has done a study on this to show the rotational stability of the accuracy of toric IOL. So this is one of the counter arguments for the LRI. So therefore you can, as I said earlier, you can fine-tune the amount. I will be brief now because we don't have much time. And what are the drawbacks of the LRIs? The foreign body sensation in the immediate post-op period, the incisions being longer than the LRIs, they cause more irritation. There is lack of precision. They are inconsistent, unpredictable. They commonly regress over a period of time. And occasionally, when you have been a little off guard, you can suddenly cause a gape which might require a suturing, especially if you haven't preoperatively assessed the amount of corneal thickness in the periphery or the place where you're going to take the incision. The most important, interesting fact of this is the cost of the procedures. I know this always brings up that, LRI is cheap and toric is, but let me actually show you the facts. The toric IOL is a one-time investment for the patient. And no toric IOL, multifocal IOL, costs more than 10,000 than what a plain multifocal IOL will cost you. Take whichever brand. It is always less than 10,000. And that is something which is going to be paid by the patient, one time. Best LRIs, we all agree, are achieved with either a diamond knife or a femtosecond laser. And I think my worthy opponent is well aware of the cost that he has paid for each of them. I know he has them both. So therefore, this cost is to be borne by the surgeon. Opposed to that, this is something we don't have to invest anything at all. The same routine phacoemulsification procedure, instead of putting a plain multifocal, you put in a multifocal toric. And there is one safe, dependable technology in which you can do both. So in the choice between LRI and toric IOLs, I think the toric IOLs wins the day. Thank you so much.
Thank you so much, Dr. Nagwekar. That was a superb presentation. So let's see what Dr. Vavekar has to say. In the meanwhile, can we just have a show of hands? How many of us are doing LRIs regularly? And how many of us are doing multifocal torics regularly? Okay. Yes, your presentation, please. It's not yet seen.
Good morning, everybody. Thank you, Dr. Anaga and AIOC for giving me this opportunity. So my topic is about LRI. I'll skip some of the slides because they have been explained very well by Dr. Nagwekar. So over here, our objective is to reduce the astigmatism. When we are talking about this small area of 0.5 to 1 diopter, what to do about this? A few years back, everybody was comfortable with 0.75 residual, but today the scenario has changed because there is a significant drop in distance visual DCVA when we don't do LRI or toric, whatever. Now, I feel that LRI is meant only for this range of astigmatism, 0.5 to 1. And of course, cost is, I'll come to the cost later. But if we leave behind, there are a lot of issues with astigmatism. And I'll skip this slide because it has been discussed properly. Now, we talk about less expensive. It is definitely less expensive. See, Dr. Nagwekar, why don't you charge for LRI separately? I charge. Then the cost, I recorded the cost of the diamond knife 1,000 years back.
1,000 years?
Yeah, I charge separately for the LRI. That is a secret. So, see, we can always charge separately because we are doing some procedure, okay? And margin for error is actually, it is not unpredictable. On the contrary, what I feel is that, if you put a toric IOL, okay, for a 0.75 astigmatism and patient is left with 0.5, it looks very funny. On the contrary, LRI, even if you go off by 5 or 10 degrees, you will be left with a 0.20, 0.14 diopter cylinder, which is clinically not significant. Unless and until you have got 0.5, we are not worried. So, on the contrary, I feel that for small LRI, small astigmatism, LRI is the way to go. Then we have got image-guided system today because of which the accuracy has because of which the accuracy has increased further. Okay, we can get LRI exactly by the degree. Then we have incorporated posterior corneal astigmatism, because of which again our accuracy of LRI has increased. Let us talk about dryness. See, dryness comes because we are cutting corneal nerves and they are entering the cornea from the periphery. But over here we are talking about very small LRI, 20 to 25 degrees arc. And if we can, because of femto, I learned them to place on a 8 millimeter circle. So 8 millimeter circle, they are very much inside. So the irritation and the dryness problem decreases. And at the same time, because of femto, they have become very, very predictable. See, one of the main reason about LRI being recurrent, the recurrence of the astigmatism, was that we were not taking proper incision. But if you see the diamond knives today, and if you see the femto LRI, you are going deep right from the beginning till the end. It is not like a shallowing in the periphery. That was the reason for relapse of the astigmatism. So because of all this, we are not getting relapse at all. And who does not have dryness today? It is ubiquitous. Post cataract surgery, the incidence of dryness is supposed to be 91%. So where is the role of LRI? Everybody is getting dryness. It is our job to assess dryness perioperatively and treat them LRI or no LRI. Then stable and sustainable, I think we already explained this point. I am charging extra for LRI, that is one thing. They are more predictable. The relapse rate is much, much less with femtosecondary. That at least you will agree. So I think overall for small astigmatism, rather than toric, I would definitely consider LRI. And last point is that the learning curve is very, very less. It's very simple technique. It takes hardly 1 minute for one LRI. And it is very simple. You come to me.
Thank you so much, Dr. Bhavekar. I hope, was this the last slide? Okay, thank you so much. So today now we have a question. Now first of all, Dr. Anurag and Dr. V.C. Mehta, sir. Now if you are talking about, for example, yourself, if you have a one diopter astigmatism and you want a multifocal IOL in your eye, what would you prefer, a toric multifocal or an LRI? Both of you.
So I have stopped guessing what is going to be the residual astigmatism, where should I take an incision, and what would happen. Just as you calculate the spherical power of an IOL, also go ahead and calculate the cylindrical power. If it shows a toric, you do a toric. Very simple.
Absolutely. But if it shows a toric, would you still go ahead and do an LRI if it is...
LRI is think of past. LRI is gone.
Truly, is it?
No, actually,
what is
it's definitely true that the addition of the femtolaser into the system and combining the paired arcuate incisions has probably resulted in a little bit of better predicament in terms of accuracy. However, in my hands, I'll definitely go in, let me give my verdict first. I'll definitely go all out for Nagvekar sir because of two reasons. One is even with variant-assisted paired LRIs at 8 millimeters, it doesn't work well in my hands at least. It might be working very well in Bhavekar sir's hands. I think the basic reason where it falters is 90% depth in different corneas yield different results. And what you do not have a hand on is the healing part. So even if it shows neutralization of that astigmatism immediate post-op, the drift always takes it back. Vis-a-vis that, since he mentioned that a 0.5 with a 0.75 residual cylinder at the spectacle plane, most probably you are going in for a T2 model in this case. And for a complete neutralization or complete failure of toricity, you need to have a 30 degrees rotation of the IOL, which is not very commonly found in the materials that we use nowadays. So the results are very stable.
So Dr. Vavik...
And moreover, when you do an LRI, it might interfere with your sight.
Yes, so that
No,
we can plan it. We can plan that.
No,
so
it cannot be within the 30 degrees of the lateral horn of the LRI, but that's something variant tells you, so it just shifts your incision to some other place.
So does it mean that one, if you want to do an LRI, you need access to a femto laser?
The
not
situation.
No, this we are giving
Not
just a
necessarily,
message. We are just, this is apart from the debate, we are just.
Ideally, yes, but
See, you require a diamond knife with, any depth possible. It's not like 500 and 550. That is a compromise. You require
Calibrated, yes.
and then you go at 85% of the corneal depth wherever you go to take it, and then it works.
But LRI, you are handling biological tissue. Your response can be different for you.
That's
That's
exactly
what
what
you
I'm
are
saying.
saying. So probably if the patient can afford, then toric multifocal IOL is the best. If the patient cannot and you have nothing else, then maybe you can go in for
He'll
an
select a toric for the patient or for himself? Because she started for everybody.
So thank you so much to all the panelists, the speakers, and the audience for giving your valuable time.
another 8,000 more.
Of course.
Thanks. Very well chaired, huh? Very well chaired.
Yes,
Only Dr. Suhas and Putin.
The way you tackle, you're very sharp to take the pertinent point, number one. And mind you, Priya was a little partial on showing her this thing where she was not showing blink. It was, you see it again, it was just an IOL. So, I mean, these things were also there. It was German. Absolutely. All other categories, she showed the blink. Or the glued lens, you see, she is a master of probably making videos, but she was definitely partial. It was just super. I mean, what an innovation, what jokes, humor, and you handling the thing. It was perfect. I want a photo with you all. Actually.
Please come, please.
Thank you.
Yeah, look here, please.